Thank you, Jacob, for that introduction. Very excited to be here and to talk about a unique opioid case. So I thought it might be helpful to share a little bit about my practice site before we dive into the didactic site. So as Jacob mentioned, I do practice in upstate New York. I'm in essentially a medical group that's affiliated with an academic teaching hospital. And so this material that we're going to talk about today is very timely, as the medical group got an opioid grant 2018, and part of that grant was to bring on a pharmacist to do opioid stewardship for the medical group. And so we did a lot of policy development. We did a lot of education for providers, patients, and support staff. And we primarily serviced at that time as a consult service. And so what we're going to be talking about today is, and now we've expanded to do a lot more things in primary care, but in terms of pain management, we're also intertwined with an addiction treatment facility, myself and our addiction doctor. So we have nice resources where pharmacists are able to make recommendations and see patients directly. So before I dive in, I don't have anything to disclose for today's presentation. And for the didactic piece, I thought it would be helpful. The case we're going to be talking about in the second half primarily involves a fentanyl patient, a patient on fentanyl, and some other pain therapeutics as well, but we're going to primarily be focusing on fentanyl. So what I want to talk about, I don't think my slides are advancing on this. Let's see. How did we do that?
Yeah, we're still seeing your
Hold
title.
on. We had this figured out.
It's working. Can you?
There we go. Is it advancing now?
Yep.
Fantastic. All right, so nothing to disclose. Okay, so my objectives. We'll talk about the dosing challenges, particularly with fentanyl and morphine equivalents. How to calculate morphine equivalents and what some of the pitfalls are if you're either coming from fentanyl to an oral opioid or from an oral opioid to a fentanyl dosage form. And we'll talk a little bit about the pharmacogenomics important of fentanyl, and then how therapeutic drug monitoring, or TDM, can be used for an individualized patient. Okay, so why fentanyl in particular? Why am I singling out this opioid? So fentanyl definitely gets a lot of bad press, I think, outside of the medical community, but it is widely used both inpatient and outpatient as a synthetic mu opioid agonist. It has a unique structure, so it's different than a lot of the phenanthrines that we're used to using in an opioid setting. It's a phenylpiperidine, so essentially it can be tolerated better by a lot of patients for different reasons, but it's much more potent when you compare it to morphine. Dosage forms are patch, intravenous, and some mucosal delivery systems. It's very lipophilic, and so it can rapidly penetrate the CNS. So for purposes of today's talk, remember that fentanyl has a 3A4 hepatic metabolism pathway. So one of the things that I get asked a lot about is fentanyl conversions. So as a pain management pharmacist, and I think when folks see fentanyl patches or talk about going to and from a patch, warning bells start to go off, red flags, whistles, what have you. And if you dive into the literature, you'll find a lot of different ratios to potentially use to convert someone to and from a fentanyl patch. I've seen them as low as 1.8 ratio, and I've seen them as high as 7.2. Even higher than that in some instances. So which one do we use? And how do we use that effectively looking at a patient case, especially safety, right? So there are two studies that I have primarily referenced on this slide and the next slide. The reference at the bottom is a fantastic resource if you're ever stuck doing an opioid conversion. Dr. McPherson does some great work in terms of converting patients from one opioids to another. But the first ratio that's commonly used is 2-to-1. So for every 2 milligrams of oral morphine per day, that's about 1 microgram per hour of a transdermal fentanyl patch. And then in the reverse, you would just half the dose, right? So about a 2-to-1 ratio is what Breitbart found. I'll also mention that you can use the Duragesic package insert, and that's this table that I've made on this slide here. And this can be a little tricky because it gives you morphine equivalent ranges, right? So if your patient's on 60 to 135 morphine equivalent ranges, they get a 25 microgram patch. I struggle with this a little bit because if my patient's on a 135 milligram, the dose doubles, 50 microgram patch versus 25 if they were on 1 milligram less per day of morphine. So this isn't my favorite, but this reference is here. And I've definitely had folks bring this up when we're talking about doses. And then ready, which is the first bullet point on this slide, is another reference that sometimes is looked at as a ratio of 2.4 to 1 when switching between oral morphine and a transdermal fentanyl patch. So there's lots of different references and resources to use. I myself primarily use the 2 to 1 method. Not only do I think it's a little bit easier for just the math is dividing it in half, right? But it also kind of gets around taking into account cross tolerance and some of the other patient-specific factors, which we'll talk about. But I just wanted to present that there's a lot of different methods and approaches to switching someone from an oral morphine to a fentanyl product and vice versa. So when we talk about things to consider, this isn't just a straight math problem. So when I teach this to students and especially medicine residents, we talk about really getting a good patient assessment before just doing a math problem and saying, this is what I want to do, right? So here are some factors to consider. And there's a lot of other ones. These are just some higher level ones for time's sake. So obviously, what is the patient's current pain level? If their pain is a 1 out of 10, maybe we don't need to do 100% conversion. If their patient's a 10 out of 10, right? And knowing that pain is subjective, we should absolutely consider their pain level. What is their total morphine equivalence? And I look at this not only as opioid in the past 24 hours, but sometimes the amount of opioid used in the past week. Sometimes patients have good days and bad days, so sometimes it's helpful to look at a weekly consumption versus just the past 24 hours. But if patients have as needed opioids, or if they're taking extended release opioids multiple times a day, which can happen, total morphine equivalence, adding that up, all different opioids consumed is really important. Do we consider the patient opioid tolerant or not? How long and how much have they been exposed to? And then adjuvant therapies become really important. What other non-opioid therapeutics are we using to treat the pain that they're experiencing? Are we planning on changing any of them? Are we titrating them up, titrating them down? And there's a lot that goes into that. But when we're doing an opioid conversion, I always like to ask, what else are we changing? What else is on board? Because that can really help how successful it will be. Drug availability is a big one. So unfortunately, in this day and age, we are dealing with constant drug shortages, particularly I'm an ambulatory care pharmacist in an outpatient setting. So oral forms of specific opioids, particularly extended release opioids, a lot of them pharmacies aren't carrying or they're on back order. So drug availability becomes a really important issue. If you did a beautiful calculation, you considered all these patient-specific factors, you come up with a wonderful plan, and then you get a message that the drug is out of stock at the pharmacy and they can't get it. So all of these things we would consider when being asked to do an opioid conversion. And then the last one, the purpose, of today, is pharmacogenomics. And how is that opioid metabolized that we're going to and from? And then also, are there any drug interactions that we're looking at? Okay, so a little bit about TDM, or therapeutic drug monitoring. So this is definitely not the standard of care. For pain management, primarily we're getting a urine drug screen. Therapeutic drug monitoring, it does require a blood draw for the patient. It takes a little bit longer. My office, it's usually about a 5 to 7 business day turnaround time, and it's more expensive. So there's some negatives to it, but it definitely can be helpful to get a serum concentration of fentanyl. Especially in the case that I'm going to present, when you're transitioning from one to the other, and it gives you a little bit of insight on maybe potentially how much opioid is in the patient's system. I do want to add, if therapeutic drug monitoring for fentanyl is something that you're thinking about doing, you do want to make sure that the patch has been on for a bit, or the patient's at least at steady state, right? You don't just put the patch on and then get that serum level. And I do want to mention there is a lot of interpatient variability in terms of what that serum level coming back means, and if they're getting analgesia from that or not. So for example, a patient's serum level could be 0.5 and they're getting great pain relief. A patient's serum level could be 2.9 and they're getting great pain relief, right? So there's a lot of intrapatient variability when it correlates to that lab value. So this is the reference that I'll be using that helps me correlate potentially what we would expect. And this is generated from several different references in terms of if someone's wearing a therapeutic dose of, or therapeutically available dose of a fentanyl transdermal drug delivery system, and what we would expect their serum concentration to be if the patient was at steady state, give or take some with a standard deviation. And so for fentanyl, primarily we're looking at 3A4 and 3A5. That's how fentanyl is primarily metabolized in the liver. So just for basic background to make sure we're all on the same page, fentanyl itself is an active opioid and it does the work itself. Once it's metabolized to norfentanyl, that's when we get into the inactive metabolite we then excrete. So just to review, there's no CPIC guidelines today. There's not really a drug label or prescribing annotation around fentanyl. ClinPharm does mention, and it's at a level 2A evidence, and I wanted to include it because that's what we'll be discussing, is potentially if a patient's 3A4 is CC or CT, they may require an increased dose. Because essentially they're converting that fentanyl to norfentanyl more rapidly. So this is where we are presently. There's a lot of ongoing research and different looks at this drug, particularly because of all the different uses, but level 2A evidence presently. So you can imagine if we're putting 2 and 2 together and looking at pharmacogenomic testing along with therapeutic drug monitoring, if someone was a rapid 3A4 metabolizer, we would expect a higher norfentanyl concentration, like I just mentioned, and a reduced fentanyl or actively active drug. And vice versa, poor 3A4 metabolizer, higher fentanyl concentration. And what's frustrating, I think, about this, and when you look in the literature about therapeutic drug monitoring, there's not a lot of well-validated or standardized references to use. A lot of what you find is from postmortem data, forensic toxicology, and even some PK studies. So there's limited therapeutic drug monitoring data that correlates to a clinical effect. But I think that's why this is a good case, because we'll talk a little bit about the gray area and how to apply what you have. So to wrap it up, some limitations and controversies on what I just said. Obviously, I mentioned that this is very patient specific, and those plasma levels don't always correlate to the analgesics effects of the opioid that you're using. Cost is definitely a barrier. Access is definitely a barrier. Like I said, therapeutic drug monitoring is not typically the standard. When we recommended doing this in my, because I'm at a primary care office, I'm not even at a pain specialty office, we had to be like, can we use it? How do we order it? How much is that going to cost? And the utility of it. So just understanding that there's some cost, access, and barrier issues if you're able to do that. But having both as a data point can be really helpful in making clinical decisions moving forward, especially with a high-risk medication like fentanyl. So fentanyl dosing is very individualized. We're going to go through a case where we apply both pharmacogenomics and therapeutic drug monitoring. And biggest, best practice takeaway is using a multimodal precision approach. If you have pharmacogenomic results available to you and you are able to do therapeutic drug monitoring, it's another data point to help you make the best recommendation for your patient. So that is the conclusion of my didactic material. And I'm going to turn it back over to Jacob.